Okay, so today we have a snow day and we've got a nice little fire in the fireplace and I'm still in my jammies, so that's why you can't see me today. Today we're going to talk about some respiratory assessment and some upper respiratory diseases. So the first thing we need to talk about is some acid base. And what is acid base? If you guys don't remember from your chemistry class, I'm not going to go into what happens when we're acidic or alkalotic and what happens at the body. I'm going to tell you how a nurse takes care of a patient with acid-base imbalance. So the first thing we want to do is look at the pH. The normal plasma pH is 7.35 to 7.45. And as you can see, we're a little acid or alkalotic. Normal body is normal pH is 0 to 14, the scale, with a lemon juice being 1, or hydrochloric acid, what we have in our stomach, is about a 2.5, all the way up to the base, which is 14, and this you might see in your sodium bicarbonate. When we look at acidosis, this is a process that either adds acid or eliminates base from the body fluid. So some things that might add acid would be drinking lemon juice, or eliminates base, could be diarrhea. Alkalosis is a process that adds base or eliminates acid from the body fluid. So again, what are some things that would add base or eliminate acid? So we have the buffer system. You should remember this from your chemistry class about the 1 to 20 in carbonic acid and the addition of water and carbon dioxide and all of that. What I'm going to talk about is the respiratory system. The respiratory system is based on carbon dioxide. We know that if we add some water with carbon dioxide, we're going to get carbonic acid. And so when we look at the respiratory system, we look at the carbon dioxide. Carbon dioxide, if we have too much of it, we have too much carbonic acid, we're going to be acidotic. If we don't have enough carbon dioxide, we're going to be alkalotic. Also, too, you want to look at the renal system. The kidneys are the primary source for the excretion or retention of bicarb. So when we look at renal disease, we would see that our patient is either saving all their bicarb, thus making them acidotic, or sometimes they get rid of all their bicarb, and I said that backwards. They save their bicarb, making them alkalotic, or excreting it, making them acidotic. So we look at arterial blood gases. You can see that the normal pH is 7.35 to 7.45. Our PCO2 is 35 to 45. Anything less would be alkalotic. Anything more would be acidotic. We also look at our bicarb. 22 to 26 is milliequivalents per liter. And then we look at the PO2, 80 to 100 millimeters of mercury, and that is at sea level. Those of us that live at a higher altitude, it would be about 85 to 100. We also want to look at our SAT, our oxygen saturation at 95%. Base excess, you're going to learn more about this in fourth semester. This is a plus or minus 2 milliequivalents per liter. So looking at respiratory acidosis. Respiratory acidosis, your patient has a low pH and a high CO2. The causes of this can be hypoventilation. So looking at causes of hypoventilation, we may have a narcotic overdose or opioid overdose. We know that when we give our patients opioids that we are monitoring their respiratory rate because it can cause a respiratory acidosis. Another cause could be barbiturates. We would again look at our barbiturates. We want to monitor their respiratory rate because it can cause respiratory acidosis. Some other causes can be something that we'll talk about on Monday, COPD, chronic obstructive pulmonary disease. The patient doesn't have enough or doesn't have the oxygen carbon dioxide exchange in the alveoli. So therefore, when we don't have the carbon dioxide exchange, we're going to have a buildup of carbon dioxide levels, resulting in an acidotic state. So our pH, our CO2s are going to be elevated. Our pH is going to be 7.35 or less. We're going to compensate for this by excreting some bicarb. This is renal excretion. Now, looking at this, it's going to take the kidneys a couple of days to recognize that we're in an acidotic state and we need to get rid of the carbon dioxide and or the bicarb. Our treatment is going to be improving ventilation. So if it's related to a opioid overdose, we're going to give the reversal agent, which is naloxone. If it's a benzodiazepine, we're going to give romazicon. If it's because of COPD, some things that we can do to improve ventilation, having our patients cough and deep breathe. Sit them up in a high followers position. And I noticed that when in the pre-test, some people wanted our patients to be in a semi-Fowlers. And to improve ventilation, we want them sitting completely up. If our patient's on a ventilator, one thing that we do is we increase the respiratory rate, improving ventilation, improving our CO2 levels, thereby correcting our respiratory acidosis. These are memory notebooks. They're loaded on Canvas. You'll be able to see them in a few minutes. And so these, I like these because it gives you a quick snapshot of what respiratory acidosis is. Respiratory acidosis, again, is hypoventilation. We see hypoxia. We're going to see those shallow respirations. Our patients may complain of a headache. They may be drowsy. They may be dizzy. They may be disoriented. We're going to see some muscle weakness, and we may see some hyperreflexia. Don't get too excited about the hyperkalemia and the dysrhythmias related to hyperkalemia because that's going to be in about 3 weeks. Some of the causes you can see: anesthesia, drug overdose, COPD, pneumonia, and atelectasis. With respiratory alkalosis, we're going to have a high pH and a low CO2. This is going to be caused by hyperventilation. So what are some causes of hyperventilation? As you all know, stress can cause hyperventilation, especially when we're overcome with stress. And we raise our respiratory rate because we're trying to compensate, and all of a sudden, boom, we're in a respiratory alkalosis. We also can see this with pain. You know, anybody who's had a lot of pain, you'll see hyperventilation. We can see this with a temperature, an elevated temperature. We can see this with anxiety. So anything that can cause us to hyperventilate. As a result, we're blowing off that CO2. If we think about it, CO2 is acid. We're going to be alkalotic. Our pH is, and there's a little typo there, is 7.45. It's going to be anything greater than that. Compensation, again, is going to be renal retention. But that's going to take a couple of days. The thing with respiratory alkalosis, the treatment is going to be fixing the cause. So whatever is causing it, if it's a fever, we're going to cool them down. Take all those heavy blankets off. We may give them a cool bath. We may have to give them some acetaminophen. If it's because of stress, well, not much we can do, but some stress management for that. If it's because of anxiety, we would use our therapeutic communication, talking to our patients, calming them down. Now, I know the video that I asked you guys to watch, Family Tree of ABGs, they talk about breathing into the bag. That's not really a recommended treatment anymore. So here again, you can see respiratory alkalosis. If it's not treated, we can see seizures. We're going to see that deep, rapid breathing, hyperventilation. Some of our causes, anxiety, fear. Pulmonary embolus, we're going to need medical management for, and we can also see it with mechanical ventilation. If our patient is on a ventilator, we may need to turn it down. With metabolic acidosis, we're going to see a low pH and a low bicarb. The cause of this is acid accumulation or base loss. So what are some causes of acid accumulation? We may see, again, like I said before, drinking of lemon juice. Base loss, we can see this with diarrhea. Our results are going to be a low bicarb level, and our pH is going to be less than 7.3. 7.35. So compensation, respiratory can compensate really quickly, and we're going to see Kussmaul respirations. Kussmaul respirations are really deep, really rapid breathing. Your respiratory rate may be 40 minutes. The treatment is going to be what's treating the cause. Some other causes of metabolic acidosis, we could see diabetic ketoacidosis, and when we talk about diabetes, we'll talk more about this. We see it a lot of times with our patients with renal failure. So the treatment may be fixing the diabetic ketoacidosis, giving fluids, giving insulin, or if it's renal disease, it may be dialysis. So again, you can see with metabolic acidosis, we can have a warm, flushed skin. We'll see muscle twitching, hypotension. They're going to be confused. They're going to be drowsy. Now you say, what's the difference? Because we just talked about, and with respiratory acidosis, they may be confused and drowsy. The difference is you're going to look at their respirations. They're going to hyperventilate. So the causes, again, DKA, severe diarrhea, renal failure, and shock. You also ask why nausea, vomiting, and diarrhea, because we said diarrhea can cause metabolic acidosis. Again, they're already acidotic, so with the vomiting, they're trying to get rid of all that excess acid so that they won't be further acidotic. With metabolic alkalosis, we're going to see a high pH and a high CO2. The cause of this is a loss of acid or a gain of base. So with metabolic alkalosis, we're going to see this with nausea and vomiting. We can also see it, especially with our older generation, when they have a little bit of heartburn. What do? They go to the baking soda, put a couple tablespoons in a cup of water, and there you have a gain of base. We're going to see a high CO2, high bicarb level, and our pH is going to be greater than 7.45. Our compensation is going to be hypoventilation. So they're going to slow it down to try and save that CO2 in order to help adjust us. The treatment's going to be to treat the cause. What's causing the metabolic alkalosis? If it's diarrhea or nausea and vomiting, we need to treat that. So it may be that we are giving our people some ondansetron, or we may need to treat the diarrhea if the diarrhea is related to C. diff, we may need to treat that in order to treat the metabolic alkalosis. So here you can see metabolic alkalosis causes severe vomiting. Oh, I forgot to mention GI sectioning, RNG tubes. We need to be watching how much is coming out because our patients can go into metabolic alkalosis. Diuretics, we see this a lot because they're losing a lot of bicarb with this. So again, confusion, dizziness, irritable, tremors, and you're going to watch their respiratory rate. So how do we interpret this? First, we're going to look at if our pH is acidotic or alkalotic. We're going to look at the PCO2. Is it high or low? If it's high or low, it's a respiratory cause. You are not going to have any compensation in second semester. That's all going to be fourth. We're going to look at the bicarb. Is it high or low? This is going to tell us if it's a metabolic cause. And then we want to look to see if our PCO2 or our bicarb match the pH. So you say, well, how do we do this? The one way that your book describes is looking at Rome. Rome is respiratory opposite directions. So if you look at the pH and it's low and the CO2 is high, then it's a respiratory acidosis. Again, respiratory opposite directions. Respiratory alkalosis, we're going to see the high pH and the low CO2. So they're opposite. Metabolic is going to be equal or the same. So a low pH and a low bicarb is going to be metabolic acidosis, and a high pH and a high CO bicarb is going to be a metabolic alkalosis. So on Wednesday, if weather permits, we'll go over some practice ABGs. Thank you and have a great day.